of Emergency Medicine here at Children's National. I'm also the co-chair along with Tamara Gale of the Social Determinants of Health Special Interest Group. And we are very happy to have all of you join us today, and especially happy to be joined by Jessica Saunders. Jessica Saunders is the Director of Community Engagement at Dayton Children's Hospital in Dayton, Ohio. Um, and, and as part of that group, she serves as the Director of the Dayton Asthma Alliance, as well as the Family Resource Connection, which connects patients with unmet social needs to resources. She also serves as adjunct faculty at the University of Dayton and at Wright State University, and holds a master's in public administration from the University of Dayton. And we are happy to have her with us, Ms. Saunders. Thank you for joining us.
Great. You want me to go?
Go for it.
Okay. Well, thank you all for this opportunity to present to you. I've always watched Children's National and all the work that you're doing, so it's an honor to present to you today. Thanks, Dr. Rucker, for the invitation. And I'm just pulling up my presentation here. Can you see it? Okay, great.
Yep.
I will get it started here. Still seeing it?
Yes.
Okay, great. So I wanted to present a little bit today about our social needs screening program. I know that every hospital, probably every department, is in a different place when it comes to social needs screening, but it's definitely the trend and the wave and the place that we need to be within healthcare, especially children's healthcare. So I'm just here to share a little bit about our journey over the last 5 years and how we have looked at social needs screening in the hospital, and actually how we are looking to scale it. So a couple lessons learned, and I hope that this is just food for thought as you are at different levels of the social needs screening program, as I understand it at Children's National. A little bit of background. I am the Director of Community Engagement at Dayton Children's, and I run what we call the Center for Community Health and Advocacy. So that is all of our community health work, all of our social determinants of health work, some of our health equity work falls under the Center for Community Health and Advocacy. And about 5 years ago, after we did our community health needs assessment, social needs screening really bubbled to the top as something that we needed to be doing to make sure that our patient families were connected to community resources and that we were addressing their social needs. So that really birthed this whole idea. And I'm showing you that this is not our full hospital. This is actually our center for, this is our Connor Child Health Pavilion, which is down the street from our main hospital, but it's the home to all of our community health programming and our primary care clinic, which serves about 75% of children on Medicaid. We also have our social needs screening program, which I'll share with you in this building, along with a food pharmacy and some other community health programming. So the hospital was really intentional to say, let's put all of this community health work under one umbrella, but also one building to streamline it and also make sure it's as comprehensive as possible. And I am eternally grateful for that investment. But I wanted to let you know where our social needs screening program kind of fits, and kind of came out of this community health work. But of course, there's this huge clinical partnership that we are working on and continuing to build. So a little bit about our journey. So we created this Family Resource Connection. That's the official name of it. It serves our primary care clinic, which I said is about 75% Medicaid. It's about 10,000 patients, give or take, a year. We're growing as we built that building. Currently we use the Health Leads model. So that's a paper form questionnaire with the questions that were developed by Health Leads, with some modifications because we have the pediatric audience. So, while we're not screening children, we're asking parents, do you or your family versus do you have, identified this need? And then currently the clinic gives the paper form questionnaire, and then that information gets taken to our student workforce. So a lot of the follow-up is being done by students that are undergrad and graduate pre-med students, social work students, led by currently just one staff person. If there's any question about the social needs or it's more complicated than a true social need, the psychosocial pieces, we definitely refer those families back to social work, and we work very, very close with social work and the rest of the clinic team. We're seeing about 6,000 screens a year with about 30% positive rate, which means at least one need. I'll say Corona has been kind of odd. Our numbers actually have gone down a little bit over the last 9 months. We're wondering if because there was such an influx of resources in our community, especially around food, we're trying to figure out that. But over the last 5 years, we're averaging about 30% positive. And then from a resource perspective, we have a homegrown resource database, and we build our own community connections. And that helps because we're community health. We're a smaller community than Washington, D.C. And so we know our community resources pretty well, but there's a lot of opportunity for improvement there. So that's been our current model, the Family Resource Connection, for about 5 years. And then we've been very lucky that the hospital has taken such a focus on health equity, community health, and actually made the scaling of social needs screening a strategic priority for the next couple years on our strategic plan. So we're taking this model that's been done in a primary care clinic, and over the next couple years, we are looking to integrate it better with Epic, which is our EMR, and standardize the questions. Right now, it'll probably be the standard questions that are coming out of Epic for pediatrics, which is a big change, but we'll make it work. We are playing around with the idea of, instead of doing this paper questionnaire, a tablet screener. So, some sort of iPad screening form. That way it's much more integrated into Epic right away. We're vetting some community resource database products, and just to kind of get out of this homegrown idea, and then really trying to provide a framework for adoption clinics. So thinking about, we have the student workforce in a primary that works, but in a specialty care setting, they have community health workers, care coordinators, social workers, nurses, like whose role is what. And that is a really fun thing to unpack in each of these clinics. So we're literally on this journey right now, but I wanted to let you know what we've done and where we're going. And so the way I structured this presentation was really kind of the lessons learned and what we're thinking about as we scale the model compared with lessons learned, and just kind of the things to think about as you are on some level of your social needs screening journey. So the first thing that, I don't know if you're familiar with Simon Sinek. He does a lot of work in business, but we've really found that the first place to start is to build your why. Like, why do you even need to do social needs screening? And I find this important because you need to find the right champions who understand this work and can connect the clinical and community and communicate to others why this work's important. Because I think sometimes clinic staff, and I understand there's so many things going on, they say, oh no, this is one more screening we have to complete. And no, you've got to connect to the fact, and we always tell that story of the child with asthma who, we can give the medication all day long, but if they're going home to a house that doesn't have, or if they don't have food on the table, mom is not going to focus on medication. She's probably going to focus on food. And so understanding the context in which our providers are giving care is really important. And so defining the why and building champions for the work. Obviously, if you're on this call, you're a champion for the work, but figuring out who are those, labeled leaders in a clinic, but also maybe the unlabeled influencers in a clinic to really build champions for this work is critical. And we find that as an important first step in the process. We also think about the why behind, there's a lot of requirements now. So I know, US News and World Report is now asking questions of whether or not social needs screenings are being conducted, depending on compliance. A lot of people are asking, are you doing this work? So some of the why is like, we're required to, right? But that's not always the best selling point. So I've kind of thought through the compliance reasons why, and then also the heartstrings why, and try to tell that story as we try to scale this work to the rest of the hospital. So start with the why and build those champions has been a big first step for us as we have been on this journey. And then this gets into a little bit more of the nitty gritty. So thinking about like, who will you screen? So in our primary care clinic, we chose that we would screen all well child visits and new patients. We don't screen during sick appointments. That was just a decision that we made, because at least intentionally screen, because we felt, that wasn't the time parents were really concerned about their sick child. We could change that, of course, but we really wanted to be consistent about hitting all of our well child visits from a quality improvement standpoint. Of course, if a social need is identified during a conversation, then we address it. But the true screening for us has been taking place in the well child visit. As we move to the different clinics, each clinic may have to identify, what makes sense. Is it a new patient? Are we going to screen every 6 months? Is it every year? So that's a big question. And also, of course, depends on workflow and whether or not you have the capacity to do that. We also, as I mentioned, that every visit or yearly visit, that's just something else to think about. And then also thinking about the unique population characteristics. So, knowing that a child has a chronic disease or is medically complex, well, asking every single time whether or not any new needs have developed might be really, really critical. Whereas with a well child visit, while that's also critical, not having utilities to make sure that your refrigerator is running for a diabetic child is absolutely critical. So we've been trying to think through, how do we do this work in a clinic, be consistent with quality, but also make sure that we're meeting that unique patient population in each of the clinics. We really found that those PDSA cycles work really well. So the Plan, Do, Study, Act, we're currently piloting our screening form and some of the workflow in our endocrinology department. And so figuring out, are we asking the questions the right way? Who's the right person to ask the questions? Are we doing it on paper form or not? All of those things are things that we're considering. Sorry, I have a little one here today. Go, go, yes, go. Go. My apologies. Go. The other question we've asked is, where will you screen? So as I mentioned, we said we wanted to do a paper form. We have found, especially when you have a parent, these are really sensitive questions, and we didn't feel we wanted to have a parent ask the question, do you have food for your family in front of a child? So we went on the paper form and we've had very good success. I think in all the years we've done it, I'm aware of just a couple families who said, I absolutely don't want to fill out this paperwork. But we are trying to figure out how do we get that into the EMR. So we're looking at the tablet. We currently screen just in the waiting room. So when the family checks in, we give the screening form with all the other paperwork that we give. That might look different in a specialty clinic where there's not as much time in a waiting room, those sort of pieces. We do think about, just the privacy of these conversations. So is it a clinic room or a private space for discussion? And then I've heard, some people are screening before, during a clinic visit, or even after. So these are just things that we've kind of gathered and we're trying to vet as we figure out how to scale. We want to say to different clinics, like, try these different things to make it make sense for your clinic. There's some things that the hospital is going to require as we scale. Everybody does it the same way, but some of these questions about where do you screen will probably depend on the clinic and what's happening there. But obviously privacy is absolutely critical. The big questions are, what are you going to screen for? There's 1,000,001 screening questions out there. There's the whole concept of whether or not they're validated, whether or not they're actionable. I'm sure if you've been following any of this work, it's just constant how it's changing. But for us, we really have been trying to figure out what are the social needs that are really prevalent for our population. For us, food, transportation are probably the two biggest, probably not too different than Washington, D.C., but I don't want to assume. So we've been trying to think about, are we asking questions that, aren't as prevalent or might be secondary questions, and making sure that we're screening the most prevalent. The other thing is, we don't want to screen and not have community resources to support that question. So are there community resources available for the questions that you screen for? And sometimes, if you don't have the community resources available, do you dare screen for that information? And there's some ethical considerations out there as well. And then what might be some natural social needs questions to ask when you're doing other screening? So that's really the concept of, different clinics are asking questions about more of the psychosocial questions. So when I say social needs, we are truly focused on social needs that are related to the social determinants of health. But some of our clinics might be asking questions about intimate partner violence, depression, mother's depression. And so there might be kind of this natural opportunity as they're doing those screenings to also include the social needs screenings. So we're just having clinics think about that as they think about their workflow. And then we really want to think about, or what we've thought about, is where can you actually make the most impact? So we're trying to do work around, if we do have a lot of food resources in our community. The challenge is connecting families to those food resources, and that's a big impact. So we're really just trying to think through, if we're asking these questions and we can give the right referrals, then can we actually make an impact for these like bigger social determinants of health for families? So those are the things that we've been considering as we thought through what are we going to screen for. You've probably seen these, but these are the Healthly's basic social needs domains of food, housing, utilities, financial strain, transportation, and then the exposure to violence. As I mentioned, we don't, like in our Family Resource Connection program, we're not asking about exposure to violence just because I have students that are responding to the needs, and that was well beyond their scope. Some clinics, of course, are asking that question separately. We also, some of the ways that you ask questions about financial strain, if you say something like, do you have enough resources to meet your needs? That's kind of subjective sometimes. So there's just a really, you want to be thoughtful about kind of the Pandora's box that you might open with those sort of questions, but also, really important questions to ask. So you can have a bit of a high false positive rate on that, depending on how you're asking the question. But these are kind of our core questions, other than exposure to violence, or 4 core topics that we ask about in our social needs screening program. And they're all things, for the most part, that we can give a specific community resource that's based on someone's zip code or their eligibility requirements, and that a student can talk to the family, kind of talk the family through. And we do specific training for our students in all of these areas so they understand the big social determinant of health and why addressing food is so important to a family, but then also, digging deeper into what the actual resources in our community might be. This is kind of the nuts and bolts, but there's so many screening questions out there. We are going back and forth about this one. This is kind of a bone of contention for us. For the past several years, we've been asking the health leads questions. I would say they're very simple, family friendly, and they are questions that are more about something like, I am experiencing the need right now and I want help with it right now. Yes or no. And the EPIC questions, I don't know what EMR you're all on, but the EPIC questions are more around, I've had this need sometime during the last 12 months. And there's a very big difference there, right? And so we're trying to think through, we want to be consistent. We want to figure out how to work within our EMR, but then how do you make something actionable if the need was something 6 months ago and not today? And so we're working through that. So I just, that's just a caution or something to think about, the value of choosing, I would say, validated screeners that are really consistent, but whether or not they're actionable in the moment, it requires a kind of additional conversation. Okay, you identified this need in the last 12 months, where are you today? Do you need help with something today? Is really that carry-on question that we have to ask. But we're trying to make sure things are always at a 5th grade reading level or below. And is this idea of prevalence of need versus wanting help addressing needs. If you have more of like a care coordination model and trying to understand the overall support that a family needs in the long term, that prevalence of need is a little bit different than wanting help today, addressing a need. So those are the things that we're working through. It is a work in progress, I'll be really honest. And different people in our organization have different thoughts about it. And so that's just something we're working through. And I think as social needs screenings develop, that's just going to be the challenge moving forward. And then whether or not you have these initial versus follow-up questions to actually do something with the information. So this is a huge area that we're like weekly struggling with to figure out as we transition from kind of the small scale to this larger scale across our institution. I think the big question is really, am I going to make my patients uncomfortable by asking these questions? And I think it's a very legitimate question. And so, for us, we've really thought about who are the right people if you're physically going to be asking these questions, or who are the right people to address a paper form, and how do we train our workforce to be more comfortable asking these questions ultimately. This is another area that we're really going to be putting a lot of effort in as we scale, because for a while, the way that we've been doing this is that we have that paper form, and then the providers in our primary care clinic pretty consistently are saying, oh, I've noticed, to mom, hey, I've noticed that you have this need. Someone from our family resource connection will follow up. Or guess what? I will walk you over to the Family Resource Connection. It's literally next door. You can get a food box today. That's worked out in the clinic when we're physically right there. But it's going to be different in each clinic as we scale, because some of the questions a social worker might come in. And we have to think that through, and really think through like what the workflow and what the workforce is, and then how to really train our staff to ask these questions, because we've had feedback. They're like, oh, I don't want to ask these questions. I'm uncomfortable. And we really want to make this so consistent that is part of care, and part that our families understand. Well, they're asking these questions because they care about us. They're not trying to bring in children's services. That is a legitimate concern that some families have said. But so we're trying to make this as consistent as possible with all families. We're asking the same questions, so they realize that this is about a new standard of care versus trying to potentially judge them. So we've felt that those first couple of months in the primary care clinic 4 or 5 years ago, I think there was some time for the families to adapt to being asked these questions. But as they came back for every well child visit and realized, oh, they're going to ask these questions over and over and over, well, okay, that is now part of the standard of care. And so now we've got to do that in the future as we scale. The other thing is that we've been piloting in one of our clinics, the paper form, and we put at the top, not, do you have needs? But it's more about, hey, we know COVID has been hard on some families. What might you need help with? Or we know that there's some stresses in everyday life. What might you need help with? So we're trying to make the questionnaire very accessible for families, and realize that we're truly just there to help, and have them understand we're asking these questions so we might be able to connect you to resources, versus we're trying to get into your business. So we know we have a lot of work to do as we scale, but that's the type of things that we've been thinking about to make this, to really get this adopted across the institution, and to have our families understand that we're doing this so that we look at the whole family, the whole picture of the child's health, and not just that clinical piece. And then the other thing is that, and this we have worked a lot with our students on, is understanding, what's the patient priorities. So when we have had families that have had 6, 7 needs, and that can be overwhelming. Of course, it's overwhelming for them. And so for us, we've said to our students, you've got to understand what's the priority for the patient today. And let's start there as we try to address these needs, and not put our own values on what they might need. So we're also going to have to be doing a lot of training around that as we move forward. And then, of course, the documentation of that we've at least addressed the need, gave some resources. That's the other piece. So we're in the thick of thinking through how we're going to train our care team members as we scale into the rest of the clinics. We have a good training for the students, but it's a very different workforce. So it's going to look different than the way we've trained our students. We can't screen and just let these families be, right? We need to figure out how to connect them to resources. So this was really important to us at the very beginning of the program. When we started it, we had this homegrown list of community resources that are put into this database that the health leads at the time we worked with to build our program. So it's a database kind of owned by health leads, but we're the ones that populated it. But we really had to think through what are the resources our community has from the beginning, and think through how we were going to do follow-up from the beginning. So, there's a lot that, 5 years ago, there weren't nearly as many resources out there as there are today. So there's a lot of resources like Aunt Bertha, Now Pow, and I think you guys probably have explored several of these, Healthify. So we're vetting those as well, figuring out what might make sense to integrate into our EMR, to make this a little bit easier for our staff and families. There's also, United Way 211 in many communities is very strong. And honestly, I tell students, if you can't find a resource, especially for our more rural communities, because we don't have every possible resource in our database, start with the county or the city resources. Those government sites have a lot of resources. So we don't want to reinvent the wheel. We've been trying to leverage what's already out there and then build upon our current relationships that we have in the community through our community health team. Different hospitals or clinics do this differently. So, some organizations, and depending on if you have, kind of these out of the box Aunt Berthas or Healthifys, you can actually do like closed loop referrals. So we're exploring that opportunity, and doing some sort of follow-up. Sometimes we've found, especially for smaller clinics, they just have to give like a resource guide. So a family identifies that they have a food need. Here's the list of all the food resources in our community. We've been trying to personalize it as much as we can for our patient families. Usually we start with looking up, where the family lives and the resources closest to them. But we also need to validate that that's exactly what they want, because sometimes families don't want to go to their neighborhood for resources and would rather go closer to where mom works, or closer to where grandparents are, because that's where the children are. So, we don't want to assume when we give resources, and those are the questions that we have. That leads into some of the cultural competency. We have a lot of Spanish speaking families, Russian speaking families, and families that speak different, dialects from Africa. And so finding resources, it's one thing, of course, in the hospital, we have translation services, but all the community resources do not. And that's a challenge for our families. And so when we built our resource database, we always ask what languages are spoken. But that continues to be a really big challenge for us. We have a lot of families that speak Kinderwanden. That's just the new refugee population that is coming to Dayton. And we have been searching high and low to find resources that can help those families, so that when we make that connection, it's a really strong handoff, a warm handoff. We do have work still to do there, but as we are vetting our resources, the cultural competency along with the language considerations are something that we're really focused on, because we know that's such a challenge for so many of our families. And then we do have a lot of relationships with community organizations. So, the big ones are like our food bank that then has relationships with all of the food pantries. We have we screen our primary care clinic sees a lot of babies. And so we have a lot of baby resource places for referrals. So diapers and cribs and pack and plays and all of those things. So we're continuously, searching under every rock for new community organizations. We want them to understand the work that we're doing, and that we're really trying to connect these families to resources. And if there's a better referral process, then we talk to them about that. So really trying to build that referral. We hope moving into a more automated system like an Aunt Bertha will help us with some of those community organizations as well. But we feel like the relationships that we have built in our community are really critical to this work. And the way I see our community health team supporting the work moving forward is that the clinics will ultimately be figuring out how they implement social needs screening within their clinic with their workflow. But if our community health team and the Family Resource Connection can have this very strong platform with all of these community resources, we can be a resource for the whole hospital in that regard. And really, understanding the relationships and the partnerships that we have in the community to support our families. So that's the vision I see over the next couple of years and how that's going to evolve. The other question, and this will come down to whatever organization you work for, but how do you document these referrals and connections in the medical record? And that's becoming, people are asking about that, CMS and others. So here again, we're trying to find a consistent way without, going overboard and having really long, lengthy conversations about it, but to say, listen, the family identified a food need. They did receive resources about, the closest food bank. So there is some of that. And as we move to EPIC, there's going to be opportunities for that as well.
Ms. Saunders, before you move on,
Yeah.
Can you repeat the resources other than Aunt Bertha that you mentioned? I know you mentioned United Way's 211 service.
Mhm.
Can you just repeat the other ones that you mentioned?
Sure. There's Aunt Bertha, Now Pow, Healthify. Those are the three, and I know there's a couple others, but those are the three that we've kind of looked at or heard from other organizations that are using them. I think there's two others, and they're not coming up to me right away. And I'm happy to follow up with you, Dr. Rucker. But there's like 3 or 4 now that are in the market, and they do similar things as far as they build a resource database. Some are better integrated with medical records than others. So it depends on what you're looking for. And then some are really doing a lot to build that resource network. But
And Dr. Long says that Unite Us is another one.
Yeah.
And to be clear, most of these organizations, or most of these quote unquote resources or resource builders, are for profit.
Correct. Yes. Mm-hmm. Yes. United Us was the other one. Yeah. So there's kind of this challenge. So absolutely. But the challenge is also, the homegrown is a lot of maintenance. So there's like that trade-off. So, and some of these have web portals, so that like Aunt Bertha does for sure. So that if you would put like your hospital skin, so to speak, like your website skin on it, but it's their database, and you can make it available to the community, not just within your electronic medical record, but available to the community. Our United Way 211 is not always as strong as maybe other United Way 211. So I think that's been one of the reasons why we've kind of had to build a little bit of our own internally. They're still a really good resource. They just don't have the nuances of, I love our resource database. It's just a lot to maintain. But for us, we have put on like what bus line the resource is on, and what language is spoken, and the hours of operation. And we actually try to, not in COVID, but previously, we would actually take our students to some of our partners in the community so that they can see and actually tell families, listen, I've been to the food bank, I've been to this pantry, this is what to expect when you go. So we don't want to lose that. I think that's really important, so that the families don't feel like they're left to just, once again, we want to make sure that they're supported. And I don't want to lose that as we transition to whatever resource we'll probably end up transitioning to. I'm gonna call. Stop. Close the door. Snow days, children, COVID. But thank you for that question. I think the biggest thing, or I didn't want to lose sight of this, is, we all want to make a difference. We know that social determinants of health are really really important, a really important part of clinical care and the work that we do moving forward. And so, to think about, how do we know we're going to make a difference? And we know that like the big social determinants of health, that is going to take every sector, big momentous movement in our society. But, for us to think about what's the end before we begin, is something that we did think about, and we continue to think about. And I think we like to frame it as like, are we making a difference for our families? And so, some of the lessons we've learned is, just understanding, as we know more about families and the context in which we live, in which they live, like, how does it actually inform your practice? And it's more of a reflection question. But early on, as we were asking this question to the providers in our primary care clinic, they were all in. They knew how important this was, but I don't think they quite understood how it would inform their practice. And so the quote I always use, and if there's any primary care physicians on the call, I think you'll understand. One of our physicians said, I know I always give like anticipatory guidance about helmets, and very important. I'm the injury prevention person. I believe in that. But if I know that there's not food on the table, that helmet conversation might not be as important this month. I need to focus on these social needs and or the basic needs. And so I think that's just an interesting anecdote that there's so much anticipatory guidance out there, but it's overwhelming for families if basic needs aren't met. And that was just one reflection that one of our physicians had. So wherever you go, and I think is a great opportunity to have all the clinicians kind of talk about, like, how is this informing our practice or changing our practice as we move forward, understanding the social needs of families, things that we may or may not have considered. We do track some key metrics. They are more process metrics than outcome measures, but we early on, and it helped us with PDSA cycles as well, but we do always track the number of patients screened, the number of patients connected to resources. We actually have kind of two ways to do that. We are tracking how many families are referred to a resource and then how many actually connect. Some families don't want follow-up. They're like, yep, I'll take your information. Thank you. Don't call me. But we do offer to call in our program to make sure they were connected to the resources. So we divide up the referrals versus connected to resources. We also track by types of resources. We know that there's certain resources like housing, for instance, you're going to be put on a wait list, unfortunately, in Dayton. We're trying to do some other things, but that helps us understand more of the problem when it comes to housing. Whereas food, usually we can, give a short-term solution for food insecurity in the moment. And then we also try to think about long-term, is this family on SNAP, WIC, and other things. But we do kind of understand the needs in our community, and we're using that information when we know it's harder for families to connect to certain types of resources. We saw some changes in the types of resources that were needed amid COVID. And it'll be interesting to see what happens someday when we're out of COVID. And we're also just looking at the number of screenings completed. That's more of a QI. Are we still, getting that 80, 90, hopefully 100% of screenings completed based on how many families are coming into clinic that day? And then, ultimately, we need to be asking families, what do you think about this program? And this is an opportunity that, we've started to do. We have not reached the plateau. There's many more hills to climb with this, but we've started to call families afterwards, after we've done our intervention, and said, was that resource helpful? We're asking questions. Was that resource, when we gave you food, was it food that you're actually going to eat? Especially, related from a cultural competency perspective. So asking families, engaging our patient family advisory committee in our program in general, but then the families that have been helped, that is something that we've started to do, but we've got a lot of work to do. But they're really the best. They're the best to tell us whether or not we're doing a good job. Of course, the other way to do this, and the other opportunity that we have, and we are looking forward to this being in the electronic medical record, to be able to connect health outcomes to these social needs interventions. We've done some of that work, but it's been pencil and paper and kind of homegrown because it's not all in our medical record. And that's one of the big reasons why we're trying to get this into the medical record, to understand the health outcomes related to interventions around social needs. So lots of work to do here, but I think we always want to know, are we actually making a difference in this world? So finally, as kind of as a closing here, and of course, all questions, please ask them. But, for us, it was about taking some first steps. So we started 4 years ago, with one physician during one clinic, using that, QI methodology, starting with one screening form and a couple questions we thought were the right questions. And we have made a ton of modifications along the way. And then as we've learned more about what questions we should be asking, and then, you've got this electronic medical record, you've got the healthifies and these other businesses coming into the environment. It continues to be an evolving field. So we're just trying to build our evidence base on what is, the most impactful. And really for us, this is a huge part of our quality improvement journey. So making sure that, we are responding to the needs of our community and of our family, looking at the data, figuring out how we do scale this in a way that makes sense for our institution, with all of the other competing interests. So, but you got to take the first step, one clinic at a time, and that's where we started, and that's been our journey at Dayton Children's. So with that, any questions, comments? I hope you were looking for.
So much. Yeah, thank you so much for your presentation. We do have a couple questions from the chat. Sure. The first is, your work is in well child visits, which are generally more low stress. And what specific thoughts have you had about translating this to, for instance, the ED, but also things like subspecialist visits or sick visits, especially for adolescents in the primary care clinic, because you kind of want to get them while they're there.
Yeah. So that's why we're doing this whole social needs work group at the hospital, is to scale it to the different specialty clinics. The emergency department, we've done, I wouldn't call it universal screening. We have the resources available, and we've done a little bit of, we'll ask some questions for those that were Medicaid, presumptive eligibility. We have presumptive eligibility in Ohio around Medicaid, but we didn't think we could bite off all the emergency department just right away. So that's one area we haven't quite touched. But with the specialty clinics, that's what we're trying to figure out through this work group. We've specifically started an endocrinology department, and we're trying to figure out, as we ask these questions, like what is different or the same about the primary care setting. And we're in the middle of doing some of that work right now. We also have our adolescent medicine clinic, and that's probably one of the next clinics that we want to scale to, because we know that's going to be an important group. And I do think for the older kids, our clinic, we unfortunately tend to lose a lot of our low teens in our primary care clinic. They end up going to a different institution, but you know, we're still, it might not be the well child. We have not explored that once a year thing, or, you know, whenever they come, they're probably going to get it for their once a year, but you're right, with those teens, it would be interesting to look at that. We haven't looked at that yet. I hope that answers that question.
Great, thank you. Do you know how patients feel about their social needs screening being in the medical record?
Really good question. You know what? It's a really good question. We haven't, I think we've just thought it's already in there anyways by just asking so what we've been doing currently is that we screen the form, or I'm sorry, we scan the forms now and put them in as a media file, and they've been there. And it's kind of part of that whole packet that they're getting for the well child visits. We do know, and this question has come up a couple of times, so we're kind of starting to explore this more. You worry about whether or not the family, especially with some of our foster families, because we have a foster care clinic, and then they kind of go back to their parents and back and forth. A couple people have asked that question, but we have not had any pushback yet. But I like that question, because then I'm like, oh, my brain is spinning and I want to go ask that question as we scale it. So I'm going to take that as an action item.
Great. And then there's been the question of how is this different from traditional social work? And I definitely like to hear your answer to that, but also any of our social workers on the call can jump in with that as well.
So for us, the first group that we went to when we were launching this program was social work. And I said, I need your blessing. I need you to know that, and they informed that work early on. We said, we want everybody to be working at the top of their license. And so in our primary care clinic, we only have one social worker, and she is busy. And it's worked out very well that, you know, she definitely deals with the more complicated cases, more of the psychosocial issues, the emergency situations. And our students are taught, like, if you hear anything that is a red flag, and we've got a list of them, it goes back to social work. This program, as it is today, is very much focused on resource connection, social needs, And I would say we want our social workers to be working at the top of their license and really working with families to do that. And we early on were double checking that we were not duplicating effort. We found there were very few overlaps in our primary care setting. With those families that were involved in social work and those that were kind of just basic, getting like the basic needs met. As we go, and I'd love to hear what social workers on the call say, as we go into the clinics, the way our hospital is set up, we have a lot of clinic-based social workers that know the families. So like endocrinology has a, kind of an assigned social worker that knows those families. And our intent is not that those families will get their social needs screening questions asked and they go to the family resource connection. That's not our intent. Our intent is that the clinic is going to have to use, this Aunt Bertha or whatever we end up using, and connect families to resources, and only come to us if it's, in a very rare case. And so I see in a more complex care environment, there will be other people that are going to help address some of these social needs. It could be a community health worker, social worker, care coordinator, and that's a big hairy challenge that we're working through, is where does one person's job end and the other one begin, and it's a little bit different in every clinic. So I'd love any thoughts on other social workers and what they've thought about. But that's something that we're working through, and it's going to look different in an acute or a specialty clinic setting than it does in the primary care.
Hey, this is Allison Page. I'm a social worker here at Children's National, and I am one of the primary care social workers. And just like your clinics in Dayton, we have one social worker per primary care clinic at our various sites. And our model in primary care looks nearly identical to your process, with the exception that once health leads left our site about 5 or 6 years ago, we hired a family services associate to do this work on behalf of our families. We screen using basically the same tool you do using health leads on a paper form. We screen basically the same visits you screen on basically the same domains you screen. So a lot of this work is the same primary care work that we are doing here at our primary care site at Children's. And also, just like you said, it's really about working at the top of your license. And so anything that has to do with abuse, neglect, mental health, domestic violence, any of those topics are automatic red flags for our family services associate to consult social work for a more in-depth assessment and to work with those families. So we are definitely involved in the process. Social work is definitely involved in the process. I developed this process for us in primary care. But I agree with you. There's work to be done that's is social work, but not necessarily done by a fully licensed social worker.
Brooke, do you want to comment at all on the difference of with something like this in the emergency department and what our social workers have typically done there?
Sure. Sorry, I'm also navigating a little person, so I feel you, Jessica.
I'm so sorry.
No, not to be negative in any way. It's a whole thing, this COVID kid thing. So I think in the ED, we, it really was in those crisis moments. And Alex, if you're looking for something different, let me know, because I've been out of it for some time. Really in those crisis moments to figure out not only, what's going on medically, but, what are all the other circumstances around that to try to support and to transfer that information to the inpatient social worker if the child's being admitted, to really ensure that we do this wraparound, and equip the social worker that they're going to be able to be prepared with any resources that might be, immediate needs, or even connections, with the community and how to figure out community support. If we have a child that, for instance, comes in, with like a gunshot wound or something like that, to really make sure that we're doing that, complete wrap, and getting insight from where we can.
we know that there's at least for us, a huge social worker shortage. And so we're pretty intentional when we hire our advocates. Most of them are getting their social work. There are various, not all of them, but many of them are, we partner with social work schools. And so we're trying to build our pipeline, to be honest. And those skills are important. And then they also they're supervised by the social worker in clinic. So we've tried to build this pipeline and give them these really rich experiences that they can translate then into their careers. We also have a lot of pre-med students and public health students, and we intentionally want them working together multidisciplinarily as students, but we're really trying to leverage the program and these opportunities to work with families as part of their education so that we can build this pipeline, because we have a shortage.
And then there's been a question about what is the financial investment that Dayton Children has made to support not health leads, because you don't have health leads directly there, you're just using their model, but your family resource connection and social determinants efforts. And you don't feel free not to give us a number, just some elements, but if you want to share a number, feel free.
So the hospital operations supports, we have a coordinator that oversees the students. So she and I, for a while, there's been some transition, and I have moved her out of any sort of grant funding, and she is like a truly operations-based budget in our like community health umbrella. And from, all of our social determinants of health work, we've been trying to align it. So, so for her, the staffing, I would say, is fully supported. And then we get like donations for families for a lot of like this stuff. We do have some money that helps to support, and for our food boxes, that's money that the hospital has given in partnership with the food bank. We've also gone after some grants together with the food bank. And then we do pay for the health leads tool still, and then we'll eventually move to like it will be more expensive when we move into that. But I think at least our hospital has been rolling it into a lot of our care coordination, and we just became part of Nationwide Children's Partners for Kids, ACO. And so now like that whole layer just literally came in this fall. And so the need to be really looking at all the social needs, I think community health is going to get lucky because we're going to get supported by that value-based care.
Yeah, it's literally what ACOs, mainly what they were for.
Yeah. So we were kind of doing all this, and I'm sure like we're kind of doing it because we thought it was the right thing to do. And then now as payment has coming along, there's an opportunity there too. So, but the staff at the hospital has invested a lot. And we were lucky that we have a space. We were so lucky. And then, that in the students, they're getting school credit for it. So you can't pay them when they're getting school credit. We've had a couple like little stipends here and there for students that were in a different model, but
basically your operations pays for a portion of the food pharmacy and the staff member who supervises the students, and that's pretty much it.
Yeah.
As
like
far as and you. Okay, great. I had a question. What you talked about, you've done some health outcomes, just preliminary sort of pencil and paper type research. What have those research questions, informal though they may have been, what have those research questions been, and kind of what was the outcome?
Yeah, so what we did was we took the social needs data and compared it. It was just a primary care clinic, of course, but we put it up against several ICD with the ICD-10 codes, just to find out like prevalence of social needs based on certain diagnoses. I don't think it's any surprise to anybody, but asthma patients, those that had failure to thrive, those were probably the two biggest ones that had, a significant number of social needs as well. We also are just trying to understand social needs based on where families are living, so zip code. And once again, I don't think we're ever surprised by that. However, the one big surprise was that we had, we always think of our city center as being we know we have food deserts. We know we have a lot of challenges within our city center, but some of our inner ring suburbs, some of the needs that came up there, I think were a surprise to us. And so there's opportunities to do that. And then, I'm lucky because I see that and then I say, oh, well, we have our social determinants of health community benefit dollars that we give into the community. I like taking that type of information and saying, well, how do we make sure that then there's stronger resources in these areas of town? And how do we support those nonprofits who need to support these families? So that continuum is helpful. Yeah, that's as much as we've done. I would love to someday look at, emergency department utilization and some of those pieces. And we've dabbled in that. Now that we'll have the ACO data, that's going to help. So it's all coming together. It's just taking some time.
That actually segues nicely into another question I had, which was when you guys started, I think of some of our inner ring suburbs, which when you compare them to cities, and most of these community resources do have some type of residency requirement, that our inner ring suburbs are a little bit less resourced than the city itself when it comes to certain things. And so I just wonder, when you guys first started, did you notice a capacity issue with the organizations that you were referring to?
Yes and no. I think it's capacity, but also non-existence of resources. So I'm thinking of I have a map in my head, and I'm thinking of one of our inner ring suburbs that was hit so hard by the opioid epidemic. I mean, that just obliterated Dayton, unfortunately. And there are just no resources there. There's no grocery stores, and they don't have the food banks set up yet. So it's more of where the distribution of resources were was a challenge. And I don't think we knew to the extent until we asked some of these questions more recently. And so the opportunity is to say, so that's the challenge, is that if we give a resource and we don't know whether or not the connection was made, the nonprofits aren't going to tell us, oh, someone didn't show up. Like, they don't know that. So that opportunity to connect to families to say, did you meet that need? Were you able to get to this resource, is a really critical component. But that's obviously really resource intensive. And some families just don't want to be bothered. Now some are like, please call me every week and help me through this. And then at some point we have to say, well, you can call us next week. We've been talking to you for a couple months, and we've scripted our students to do that as well. But yes, there have been, it's more access or resources in the right location, I think, is the challenge, versus whether or not we had an organization that reached capacity. It's more that there wasn't a resource there.
All right, guys, we're right at 1 p.m. Does anyone have any last short questions? All right, well, hearing that, I want to thank you so much for coming and joining us. This has been extremely valuable information, both for our special interest group as well as for the hospital at large. And I invite everyone on the call, if you've not been connected with the Social Determinants of Health Special Interest Group, you can email Elizabeth Bartlett, and that's with 2 T's at the end, and she can get you set up. And we will send out information very soon about when our next meeting is. And thanks again to Ms. Saunders. We really appreciate it.
Thank you all.
Thank you very much.
Great. Have a good day.
Thank you.